So on behalf of the Victorian Stroke Clinical Network, welcome to this stroke session number 38. Today's topic is the Chronic Stroke Review Tool and Intervention Guide, the REV-TIG, development and pilot implementation. So our presenter today is Dr. Kim Brock, Neurological Physiotherapist at St Vincent Hospital in Melbourne. Thanks, Kim. Over to you.
Thanks very much, Patrick, and thank you for the invitation to speak today and to everyone for dialing in. This is my first time with this new technology, so we'll see how we go. As Patrick said, discussing the development and implementation of the Chronic Stroke REV-TIG, as it's now known. It used to be known as the Chronic Stroke Resource Kit, but someone very sensibly pointed out that the review tool is a very important part of it, which is why the name change. And I'd particularly like to welcome people who helped out with the development and implementation of this who are attending today, and that's you for one, Melissa Ho. Right, so to move on. So as we all know, stroke is a leading cause of long-term permanent disability, and issues of depression, limited participation in community life, and poor quality of life are well documented. There is evidence to support use of community-based rehabilitation interventions to improve function, reduce depression, and enhance quality of life into the chronic phase of stroke. And particularly want to acknowledge one of the colleagues working on this project, Christine Graven, who published in 2011 a systematic review looking at exactly this question, rehabilitation interventions that improve function, reduce depression, enhance quality of life. And that work, as part of her PhD, has been a major focus of this project, a real driver for the project. And when we were putting this project together, things that we really wanted to focus were facilitating community integration for people with chronic stroke and promoting healthy and active lifestyles. And there's a big focus about engaging healthcare resources into the chronic phase post-stroke. And I think in Victoria, the needs of our stroke patients in the acute and the subacute and the community care after the initial stroke are world-class. But perhaps in the chronic phase of stroke, that's perhaps not quite so true. And the real driver that got the project underway was the stakeholder consultation that was carried out as part of the Victorian Stroke Care Strategy in 2007. And they spoke to a lot of people who were survivors of stroke and their carers. And one of the main things they wanted to talk about was services for people in the chronic stage. And this point was made in the report that patients would benefit from intermittent access to community-based services at pivotal points over the recovery pathway. And a goal of the REV-TIG is to really facilitate this to happen. The National Stroke Foundation guidelines recommend annual review for people with chronic stroke with ongoing impairments, both in terms of their current status and whether there are merits for further intervention at that point in time. So can we better use our community rehab resources in Victoria for people living with chronic stroke? So in the development of the REV-TIG, our objectives were to complete a literature review of evidence-based practice in the management of chronic stroke survivors, to create well-structured and easy-to-use documents summarising these findings, to develop a comprehensive multidisciplinary assessment form. So a form that anyone could pick up who works with stroke patients regularly, be it a physio, an OT, a speech, a stroke liaison nurse, and work their way through the assessment form confidently. We want to identify flags within the assessment form that indicate that treatment interventions should be considered, then to give some intervention guidelines based on the evidence, including referral to other health services, And then overall, with the goal of assisting community organisations providing stroke care to meet the recommendations of the stroke care strategy for Victoria. So within the RevTIG, there are these 10 domains, and we're going to go through each of these one by one. And for each of these domains, there's introduction, including key literature in this area. There's the assessment component. There's the flags for intervention, recommendations for intervention and referral options, and there's a reference list with reading in that area. And also at the end of the RevTIG, there are 3 case studies to give examples of how the tool might be used. And there's a summary screening assessment, so 2 pages that can go in a medical history or be sent to a GP to keep a record of what occurs in the assessment. So the first thing in the assessment is participation, and really the whole process of assessment is built around this, people's participation in their family, domestic, community life. So in the introduction to this area, it gives the definition of participation as involvement in a life situation, a good broad definition, and they talk about activities that are valued and meaningful for that person. So it's very individual, whether it's a domestic situation, about socialising, about leisure activities. And we know that there's a link between low levels of engagement, low levels of participation in social, leisure and vocational activities, and poor life satisfaction and with depression. So the questions that are in the kit are what activities did you enjoy prior to the stroke? What activities do you enjoy or value now? And then for those activities, how often are you doing those activities? And then what stops you from engaging in activities that you enjoy or value? What are the barriers for you? And the flags for participation are failure to get back to valued activities. So here comes immediately the other main factor in the RevTIG, which is goal setting. So if you're talking about participation, it's identifying the valued activities and then setting goals in those areas. There might be targeted rehabilitation services. It might be somebody's concerns about balance that are preventing them from making that first step to walking down the steps into the bowling club. It might be an indication for leisure therapy. There might be barriers that could be addressed, particularly about transportation. It might be about their social network and whether we need to find new ways for them to be able to access things that they previously did. And then, is it going back to an activity that they valued, that they previously did, or is it looking at some modification, a different angle on that activity that you could problem solve through that would get them back into that thing that they enjoy? Within participation, we also ask, who do you see regularly? To really find out what is the social network the person has to support them. The next thing on the next domain in the RevTIG is functional decline. And we know, for instance, that 20% of people with stroke have a decline in their walking ability within 3 years, and that functional decline is linked with low levels of activity and depression, same factors coming up again and again. Also impairments in cognition and fatigue. Fatigue is reported in 40 to 70% of people with stroke in the first year. And the definition of fatigue is a weariness that's not related to previous exertion levels and not improved by rest. So the questions we ask in the functional decline domain is, how has your mobility been recently? Has it changed? Is it better or declined? And what caused this change? The same question about arm function, performing self-care tasks. So we're certainly looking for a decline in function, but also if people have had further improvement, maybe that opens up more possibilities from a participation point of view. So looking not only at the negative but also the positive. Asking about fatigue and then continence. So in terms of flags, certainly a deterioration in mobility or function is a flag that this needs to be investigated and to see whether there's any interventions that could reverse that trend. Perhaps specific mobility or functional goals can be found that could be achievable with a short burst of therapist input. And certainly fatigue is limiting. Is there things that can be done to improve that? In terms of interventions in this area, a referral to therapists or to continence services or community services. For fatigue, the literature recommends practical management strategies, energy management techniques, exercise, good sleep patterns, avoiding sedating drugs, this kind of practical things. There's also specific interventions that have a good evidence base in chronic stroke, so certainly cardiovascular exercise, strength training and gait retraining all show benefits for people with chronic, in the chronic phase of stroke. And there might be a point in people's lives where they feel like this is a good time to take up these kind of activities. The other thing is that the rehab field moves on and new things arise, particularly the much greater use of botulinum toxin A now, changes in ankle-foot orthoses, all sorts of exciting electronic things that come up. People with chronic stroke need to be considered for these interventions as well as people with new strokes. So can we do something useful about function? And in this area, there's 22 references that you could follow further. So for each area, each domain, there are references for further reading. I hope I'm not speaking too quickly, and I hope I'm loud enough. If anyone has concerns for either of those things, could you just type me a little chat message, and that would be good. Moving on to the next domain is about falls, and we know that long-term community dwelling stroke survivors have twice the risk of falling. In fact, 40 to 70% fall within the 6 months of returning home, and then many continue to fall. Again, there's a link between falls and depression. And falls have a substantial impact on confidence, mobility, function and independence. So not going out might be because of a fear of falling. And there's stroke-related factors that impact on their falls risk, but there's also independent risk factors, as for any perhaps elderly people, that may increase the risk of falling. In terms of assessment, we ask the person whether they've had any falls in the last 12 months, and then, of course, if yes, what were the circumstances, etc., etc. But also, do you worry about falling? Maybe they haven't fallen, but they're concerned about falling, and that's something that stops them getting out and about. So the flags are those two things. In terms of interventions, there's certainly evidence that exercise interventions are useful. They found that for a balance training program, it needs 50 hours to be effective. So that's quite a bit of practice. And also that it's not wise to give someone a walking program as a single intervention. They might well fall when they're out doing their walking program, but a walking program embedded in a balance program that is a far better option. So that kind of information is included in the interventions list. Also, looking for a medication review might be something to consider with falls. And then management of specific impairments, for an example, a person with a visual problem, and then the usual referral to OT and physio for falls prevention and home modification activities. Moving on to communication. So people with chronic aphasia are at risk of increased socialisation and reduced participation, and certainly depression is a problem with people with aphasia. And in our RevTIG, the approach taken is a social approach to the management of aphasia. It's about functional communication and a focus on the person's participation. It might be about conversation partner training. It might be about the use of communication aids. Perhaps the person wasn't interested in using these kind of things in their stroke journey, but 12 months has gone past and maybe they're in a different mind frame and are more open to looking at things. Maybe new things have come along that they haven't been offered in the 10 years they've had since their stroke. So as far as questions go, the assessment questions, do you have difficulty communicating? Has this changed? And does your communication ability impact on your ability to participate in other activities? And interventions aim to address the participation domain and re-engage in the context of communication impairment. Includes referral to communication support groups or leisure or social groups, and of course the speech pathologist being key here, but perhaps not the only thing to be considering. With cognition, we focus on a person's independence and ability to participate again, and to take up their pre-stroke roles, many of which require complex thinking skills. And certainly in this stage of assessment is cognitive impairment part of their stroke. The questions we have on the RevTIG, sorry they're not on your screen, is has your memory or thinking abilities changed recently? If so, what has caused this change? Are you able to remember the things you need to remember? Do you use any strategies to help you remember things or organise your day? So we're interested in the functional consequences of any cognitive impairment. Is it about managing finances or using computers? So it's looking at the patient as a whole person and working out whether there are rehabilitation interventions or other types of interventions that could improve things for the person at this stage of their stroke recovery. And then if it seems necessary, going more into cognitive function by watching the person do a familiar task. So the flags here are a further decline in cognitive function and any safety concerns that arise. Certainly referral to OT and speech pathology. Using the CADMs, a lot of our, I think all of our community rehab SACS type services have access to the CADMs set up for Alzheimer's and similar disorders, but which can also be very useful in chronic stroke. And then again, use of technological devices, the era of the smartphone, and how that can be used to get around problems, and whether it's the person or their carer, is there a way to make life easier using new technologies. So moving on to depression, and depression and the high incidence of depression. 1/3 of people following stroke are likely to experience a period of depression. Again, was one of the major drivers of the chronic stroke RevTIG being put together. Depression is defined as a low mood for more than 2 weeks, plus at least some of these factors: low energy, low appetite, disturbed sleep, sense of worthlessness, agitation, and quite a few more. And depression is certainly associated with poor outcomes after stroke. Factors that make depression more likely is the severity of the stroke, physical disability, cognitive impairment, and also a past history of depression. So we know that depression can affect the recovery process and the ability of the person to participate in rehab programs. We know it's under-recognised and under-treated, and it can restrict a person's ability to return to valued tasks and activities, and can affect community reintegration, and that it can be successfully managed with appropriate interventions. So with the assessment, firstly there's a question about whether the person has a history of depression, because that is a strong predictor of depression being a problem post-stroke. And then we use the geriatric depression scale. So this is the only standardised measure that's used in the chronic stroke REV-TIG. Generally, we have tried to keep to simple questions in each domain rather than using standardised measures to make the assessment manageable, and to promote interaction and conversation between the person interviewing the person and the stroke survivor. But for depression, we really felt that embedding a measure was essential. The geriatric depression scale has 15 questions, and it's just a yes or a no. Questions are things like, do you feel that your life is empty? Do you think it's wonderful to be alive now? Do you often feel helpless? Do you feel pretty worthless the way you are now? Do you feel that your situation is hopeless? So there's 15 questions, and if you get a score of 6 or more yeses, then that is a time to be quite concerned about whether the person has depression at this present time. I've often, having used the REV-TIG with patients, I've had patients that come in to me and say, how are things? Yes, I'm fine, it's good, family's all good, we go through the session, we work together, everything seems fine. And then you sit down and do the geriatric depression scale, you get to the hopeless question and you get another yes, and you think, oh, gee, I would have missed this if I hadn't gone through the screen. So I think it's an important thing for us to do. Looking at interventions for depression, first of all, referral to the GP for a consideration of medication. There's good evidence that giving medication for post-stroke depression is efficacious. There's also medication needs to be used carefully, so person needs to be well established with GP involving taking medication. But there's also evidence for things like motivational interviewing, back to goal setting again, to help people make plans in their lives to help them move forward. And exercise. There's evidence in chronic stroke populations that exercise can, along with other treatments such as medication, can be effective in reducing depression. I think one of the values of the chronic stroke REV-TIG is that perhaps as clinicians we feel a bit nervous about asking questions like, do you feel hopeless? Because what will we do when they say yes? To feel that you have some tools that you can offer, that you can certainly write a letter to their GP and then follow it up if they don't do anything about it. But also that you can get some exercise interventions underway, you can talk about goals with the person, so it can be a multifactorial intervention looking at this issue of depression. And then monitoring over time how the person is travelling as well. So health-related quality of life is included in the tool. Health-related quality of life includes concepts such as your personal relationships and your role in the community, your psychological well-being, and perhaps your sense of safety and other things as well. There's a simple question in the assessment, just how satisfied are you with your life as a whole? And if people are saying, oh, I'm not very satisfied, which aspects is it? Is it about their health? Is it about their personal and family life? Is it about future concerns, fear of what might happen in the future? So within that, are there things that might be modifiable? And if so, are there resources or services required? Also, the opportunity to, again, in the interview, to get a deeper understanding of the person. We also ask, are there goals that you could pursue that might influence your quality of life? So the next domain in the tool is secondary stroke prevention and risk factor management. So we know that people who have had an ischemic stroke have elevated risk of recurrent stroke events. And in fact, that if you adopt 5 key prevention strategies, might reduce the risk of a further stroke or myocardial infarct, because they travel together, over a 5-year period by 80%. And what are the 5 key prevention strategies? Diet, exercise, and then aspirin, a statin, and an antihypertensive medication. So we certainly have a role in rehabilitation with diet and exercise, but also, are people aware of their stroke risk factors? Are they seeing their GP and being reviewed? Or were they given some scripts when they were first discharged from the hospital, and then they thought that was only for that time and they never got those scripts renewed, and they're not actually having any secondary stroke prevention? Or maybe they have the scripts, but they have difficulty getting them filled, or they can't remember to take them, or what is stopping secondary stroke prevention from happening in a real-time way? The other side of the coin is post-stroke complications, things like infections, pain, and management of pain, spasticity. Again, there might be new, certainly for post-stroke pain, new medications coming on board, and spasticity the same, that people are seen appropriately for this. So flags within this assessment is the does the risk factor management seem to be suboptimal? And we need to get this person into a better situation of seeing their GP more regularly, or perhaps review by a rehabilitation physician, something we can often access in community rehab networks, might get a much better control over the situation. Do post-stroke complications need to be looked at, and are they being reviewed annually? And interventions, referral on being key in this area. But perhaps as rehabilitation clinicians, allied health clinicians and nurses, we can do more to make sure our patients are getting good secondary stroke prevention going on. Carer support. So we know that adverse carer outcomes are common. Depression and anxiety, decline in carer health, and a reduced sense of autonomy. We know that some patient factors are particularly related to poor carer outcomes or carer burden, certainly the person's level of disability. Depression, caring for a person with secondary depression following stroke. Patients with personality and behaviour changes, incontinence and cognitive deficits have all been shown to be associated with heightened carer burden. We have to remember on the other side that carers very much can contribute to the recovery process and find that to be a good experience, and that positive aspects of caring can also emerge. So within the assessment, we ask, what does the carer do with or for the patient? What formal and informal supports do they have? Do they feel that they're currently coping at home? And should we screen for depression for the carer? So if you have a concern, doing the GDS with the carer, or doing a carer burden measure might be appropriate in this case. If there's reduced carer coping, what interventions can we consider? Actively engaging the person in the rehab process, allowing time for carers, education, working through coping strategies, looking at respite options and financial assistance, and just that ongoing relationship to try and get the ship back on a more even keel. And then the last domain of the chronic stroke REV-TIG is goal setting. So we start with participation. What did the person do in their life before the stroke? What are they doing now? And then by the time you've gone all the way through the assessment and you know a whole lot more about the person than you did before, perhaps it's possible at that time to go on and think about goal setting. Perhaps you need to get to know the person a little bit more before you can go on to the goal setting aspects. With goals, of course, we want them to be person-centred, and we're looking at activities that are intrinsically motivating for the person. So they may not be able to put their shoes and socks on independently, but if they're quite happy for their partner to help them, then that's not an intrinsically motivating goal. We need to get to know the person in order to assist them to set meaningful goals and empower and support them to make behavioural changes. We need to gather insight into the person's perspective about their own situation, how they feel about how they're travelling themselves. And we're very much looking at setting goals in the realms of social functioning and community integration. So all the goals up there reflect those kinds of things, and devised in terms of what the person did do before or wants to do at the moment. Certainly we have problems with patients whose goal setting is too optimistic, and maybe we need to decide on smaller goals that head towards that larger goal that they want, and perhaps over the process of working towards a smaller goal, their perceived attainability of their valued goal might change. They might realise that one's a little too much of a stretch as the person adjusts to what their ability state is. So rather than pouring cold water onto their goal at the start, working with them until they get clarity themselves about what their future directions, and instead of going in one direction towards the goal, they go slightly differently to a slightly different goal that's more achievable but still in the same realm. Alternatively, you get the patient who hasn't got any goals because they don't think that they can do any of the things they used to do. Just wipe it off the slate. So perhaps with those people, you work down to find what is the easiest thing that would feel to them might be most possible. Start with that and work through a process of discovering that in fact they can perhaps do more things than they had thought they could. Certainly all goals need to follow some version of the SMART formula. So ours is specific, measurable, attainable, relevant, time-bound. But certainly the goal-setting component of the REV-TIG, of the review tool, is what the whole thing is hung around, and that's the intervention tools would be designed to help meet those goals. So that pretty much covers off the development of the chronic stroke review tool and intervention guide. And what I'd like to talk about briefly now is the implementation. So we did a pilot implementation, and this is the methodology of the implementation. First of all, we ran a train the trainer workshop. So we invited people from community facilities to come and attend a one-day workshop about the review tool and intervention guide. And we did some surveys of those clinicians, the willing clinicians. And then they went back to their various centres and implemented the tool with stroke survivors. They conducted the comprehensive screening assessments. We gathered information about the services and therapies people were receiving before and after the review tool. And we asked each of the clinicians who engaged with patients with the RevTIG what their view was about the utility of the tool for that particular individual that they were seeing. Then we also gave questionnaires to the stroke survivors to get their view of the tool and the clinicians at the end of the study. And we conducted a focus group with stroke survivors and carers. And I'm particularly going to present some data where the red stars are about the implementation. So we had 16 clinicians come to our Train the Trainer Day from 10 different community settings. And you can see there that they were both community rehabilitation and community health and a stroke liaison, and both metro and rural centres who actually implemented the RevTIG in their centres. If we look at the stroke survivors, there were 30 stroke survivors who took part in the study. And they had a median age of 60, so definitely down the young end of stroke survivors. 63% were male, and they had a median time since stroke of 12 months. So again, they were the more recent stroke rather than the chronic 5-year, 10-year people with stroke. In fact, the patient with the longest time since stroke was only 21 months. And 83% of these were people already attending the community setting. What this means is that we captured people who were perhaps at the tail end or being reviewed after their initial community rehab episode, and that during the time of the study, which ran for between 6 months and 15 months at different centres, there were very few people with chronic stroke who were referred to and attended these centres. So one thing it demonstrated is that people with chronic stroke are not accessing our community rehab resources, even though these community rehab resources are very keen to provide services to these people, keen enough to show up for a one-day Train the Trainer and then run a whole study without any remuneration. So we have a problem in that regard. For our clinicians who took part in the study, there were 12 clinicians who filled in the SurveyMonkey questionnaires following the implementation, 6 OTs, 5 physios and 1 nurse. And you can see that they were mostly an experienced bunch, with most of them having 5 or more years in practice. So when we asked our stroke survivor participants, if we asked them whether they thought it was worthwhile participating in the assessment process, and they were all either somewhat worthwhile or very worthwhile, which was very good of them given they were already attending the rehab centres for the most part to sit through another assessment, but nonetheless they found it worthwhile. And we asked them whether the domains that were covered in the assessment were important or not important to them. And you can see there in the blue that the majority were certainly felt that these activities were important and that we should ask stroke survivors about these questions. We asked our participants about their confidence to engage in certain activities, and my little red dot here that Pat says can show you things. If you look at this exploring alterations in mood one in the middle here, you can see that blue and red is very confident or quite confident, and green and purple is neither confident nor not confident. So, more than half of our clinicians were neither confident or not confident to explore mood, and that changed to them becoming very confident or quite confident to explore mood with people with chronic stroke. So we were very pleased about that, because that was certainly one thing we wanted to get change in. The other thing that we found interesting was that in terms of exploring options to improve participation, again, there was a movement towards this group here who were neither confident or not confident to becoming more confident to explore participation with stroke survivors. So again, that was an outcome that we were looking for. On the other aspects, the clinicians were doing pretty well even at the start. Perhaps again, carer support might be something that needs some more work. We asked our clinician participants whether they would recommend use of the RevTIG to other health professionals, and for the most part they strongly agreed or agreed. And one in particular made the point that the RevTIG focused attention on areas of importance to the stroke survivor, and certainly that was our goal in putting it together. There were areas identified for further development. One of them is emotional changes after stroke and adjustment to major life changes. So we're looking at the moment at some work to include these in the RevTIG. Community access was another area, and sexuality and intimacy. I think we're fortunate that the VSCN has been doing work in some of these areas, particularly sexuality and intimacy, that we are planning to draw from that work to add it to the RevTIG. The other area that's not covered is self-management programs, and again, that was because the VSCN and the National Stroke Foundation doing very good work in that area that, again, we will be drawing from to add that information into the chronic stroke RevTIG. From the conclusions, the assessment domains and processes in the RevTIG were perceived as important and worthwhile to the survivors of stroke, and clinicians reported improved confidence in working with key domains following use of the RevTIG. And the RevTIG was published at the VSCN, but the website's being updated at the moment, so that's why Patrick sent you out a PDF copy so that you can't click on that tool and get to it at the moment, but hopefully it will come back again when they've finished sorting the website out. In terms of future directions, we're looking at reviewing and modifying the RevTIG in response to feedback from consumers and clinicians. So certainly those areas that I pointed out before, that's our first concern. And then how to implement the RevTIG more widely. We had put in a grant in conjunction with the National Stroke Foundation to look at developing a web-based platform, and I was very pleased to find out last week that that grant's been approved. So watch this space. Hopefully on the e-learning part of the NSF, we should have a chronic stroke education area based on the RevTIG tool, and it'll be a lot more user-friendly than the paper version that you have, your PDF version that you have now. We're also looking at whether we should take a competency-based approach where the education information is set at two levels. One, a fairly basic level where students or people new to community rehabilitation can look through and follow up their areas of interest, and then at a deeper level where experienced clinicians would work through a series of educational activities, do the usual online assessment processes and become an accredited assessor on the tool, so that in our standardised assessment form, summary form, we'd have a little tick box down the corner that says whether you're an accredited assessor or not. And perhaps being an accredited assessor could be something that would help to get annual reviews of people with chronic stroke in our community rehabilitation centres a lot more common than they are at the moment. And lastly, I'd like to acknowledge all the people who worked on this, all the people who were involved in the development of the tool way back in 2011, Patrick and I thought it might have been, and all the sites who carried out the initial implementation. And then if I can go back to the first slide, will this work? No. Patrick can put me back to the first slide. I can take us back there very quickly, just to thank all the people who worked on the development of the tool, particularly Melissa Birnbaum and Christine Graven, and the folk at Monash University and the Florey Institute who helped us with the implementation, Dominique Cadillac, Karen Moss and Tara Purvis. And thank you very much. And there's no questions in the chat box, Patrick.
Well, people have been riveted, I would say, Kim, and not had the opportunity to post one. But there's no hesitation now that I see Ballarat Health is responding. Maybe I'll kick something off anyway. As one of the original pilot sites back in, what did you say, 2012 or thereabouts, I certainly found it to be an extraordinarily useful device for following up patients in their chronic stroke phase, and it certainly resulted in quite a few referrals, you know, going back to, say, even counselling and support or occupational therapy, etc. And we also used it to link people into our stroke self-management program also. So we found it very useful. But anyway, there is a question there from Ballarat Health. It says, "Hi Kim, how long does the assessment take to complete?"
Yes, it's a very good question. Difficult to answer, I'd have to say. The assessments, it's an interview really. So some interviews are very quick. The person's very quick to tell you, yes, I'm back to the things that I did before, and no, I've got no problems with my walking, it's getting better, and you whip through the GDS. They're just saying no, an occasional yes, and the whole thing's over in half an hour. And somebody else for whom the questions are quite concerning, what I did before, what I did now, what my goals might be, it might take you 2 sessions of 45 minutes to get to the end. Yes, so it's a difficult question to answer. In my experience with it, I'd say for me it took for most people about 40 minutes for your average stroke patient. And there's another question here from the F. I'm not sure who the F is. Is the GDS validated for use in younger stroke survivors? To my knowledge, it isn't. The reason why the GDS is chosen is it doesn't have any of the usual questions about whether about sleep disruption and physical feelings of weakness that aren't appropriate to a population with stroke, because patients are going to feel these things, or particularly weakness, because of their stroke, not because of the depression. So that's why the GDS was the tool recommended to us by our psychiatry team. And now there's so many questions here.
Yeah, that one would have been the Florey, I think, Kim.
The Florey. Oh, very good. Yes.
Yep.
The next one is Peninsula Health. Shall I just move through these, Patrick?
Yeah, go ahead at your leisure, Kim.
Yes, great. Peninsula Health, do you have any idea on how to access clients who are discharged from a community rehab program following their block of therapy? Yes, I do. An annual review, which in the SACS funding model, in the way that people re-enter SACS and have to go through a comprehensive assessment and all those things, takes a little bit of working through with your management, I'd have to say. But certainly in our SACS service, we book very often folk for 6 monthly reviews initially. And then if we connect it to the previous booking if it's just a one-off, and then it's a whole new episode if we determine there's rehabilitation interventions to be conducted. But it certainly takes some thinking about and working through with the funding model we have with the department. After that, when things are stable, we book them for a yearly review, and then we just ask them to get their GP to refer them like they would at any other time, and we keep a diary and send out a reminder notice that it's time for your annual review. So that is that one. Wodonga. Thank you, Wodonga. Rachel, what screen do you recommend for carer burden? Now, that one I will look up because the name escapes me. Oh, the ZARIT, Z-A-R-I-T, carer burden scale, and you will find the reference to that in the PDF tool that you have there. Next one is the Florey. Why do you think long-term stroke survivors aren't attending community rehabilitation or community health? I think the reason, I think there's two reasons to that. I think that GPs don't refer people, but I think that GPs don't refer them because they have referred someone before, and they've gone to the centre and had their assessment, and they couldn't think of any goals, or realistic ones at least, at that assessment. So they were told that the service couldn't do anything for them, and they went back and told their GP that, and then the GP didn't refer anybody after that because that didn't work. So I think there's us working out ourselves as community rehab facilities what we can offer these people and how to go about that, which I hope the RevTIG helps with. I think there has been a tendency for people who've had a stroke, who sprained their ankle in a fall, to go into a community rehab centre, be treated for the sprained ankle and then discharged before you open that package and find out what's really in it. So I think we need to open the package and look at the whole person. I think when we as community facilities are doing that well, then we need to say to the GP community, you know those patients sitting in your waiting room who just make you feel sad every time they come in, well, send them to us because maybe we can help. And I'm actually meeting with the GP stroke education person next week because GPs are very keen to find out how they can help their patients with chronic stroke. So I think this is a bit of a long journey for us as a community, but I think it's a very good boat to get on. Next question, BGM. Where mood disturbance is of concern in patient and or carer, what suggestions are made? Where are they referred to, if at all? Certainly, with mood disturbance, consideration of medication needs to be undertaken. Whether it's given or not is another question, but it needs to be considered. So back to the GP is always the first call, and I know sometimes GPs would like to be able to access psychiatrists, and sometimes that's very, very difficult with long waiting lists. So the GP ends up being the person who manages the depression from a medication point of view. But I think what we need to take on board as rehabilitation professionals is that there's things that we can do in terms of people's personal goal setting and moving forward, in terms of getting them into a more active life, in terms of exercise that can be used in conjunction with medication, if that's deemed appropriate, to help people move on from their episode of depression, as can certainly happen, and go on to a more full life. Yes, there is limited access to psychologists for people with chronic stroke. I do agree, and I think many of us feel that this is a big problem within rehabilitation services generally, not just for people with chronic stroke. So it would be great to see movement on that. But in the meantime, well, at the moment, I don't think anybody much is holding the baby. But perhaps we can at least make first steps with people, and certainly the evidence on motivational interviewing type, behavioural type interventions being efficacious, certainly in conjunction with medication, is something we need to take on.
Look, thanks for presenting on this wonderful topic. As you say, it's been a fairly long work in progress, but it's looking very encouraging and something that would be a great resource for anyone with the capacity to go into chronic stroke.